All right, good morning, everyone. It's 7:01. So why don't we get started with neuropathology for this month? Long, are you there?
Hey Victor, I'm here.
Good morning. Let's go with this case, and we'll get us moving. A 64-year-old female. This is a UN patient, ultimately seen by Dr. Ivan. But I would say almost 30 years ago, she had a left eye tumor removed at an outside hospital, and was told there was residual, but she can't recall the pathology. And about 5 years ago, she then noticed continued left proptosis and had a nucleation at another outside hospital. Effectively 20 years later, no radiation history, still can't recall what the pathology was, unclear as to the true course, but she continued with left proptosis and presents now for further concern of this. She had other surgical history. She had a previous aneurysm embolized. That's not particularly pertinent to the current presentation, and otherwise unremarkable history. On her neurologic exam, she truly only has this left proptosis. She has no left vision as expected. And so long she comes to you with this imaging here. So why don't you go ahead and just quickly just say what slices, sequences we're looking at and what you see here.
Yeah, so this is a CT, a bone window, soft tissue window, axial and coronal. Appears to be a large isodense mass in the left orbit. On the bone window appears to be there's maybe some scalloping of the bone, the periorbital bone. I'd like to get a follow-up MRI with her.
Sure. So what they actually proceeded without an MRI, primarily because there is a lesion here that is causing symptoms. And they had a differential in their mind when they went ahead with that decision. Do you have any idea what this could be?
Mm, I guess could potentially be a primary tumor of the orbit. Could be a met. Um, could be potentially like another sort of some like squamous cell carcinoma.
Exactly. You're getting all the ones, hitting them all on the head. It's hard without an MRI, and you have to forgive me for not being able to find one. But ultimately, you're right. It's an intraorbital mass that is causing symptoms, and the differential can be quite broad. Common things being common. One thing could be a meningioma, right? In this setting, but again, something that looks like this truly needs tissue for diagnosis. So another consideration is solitary fibrous tumor in this case, and then obviously other sort of masses that occur within the orbit, as you listed there as well. And so, treatment. What do you think you would like to try to do for this patient?
Yeah. So I think sounds like a recurrent aggressive lesion, given that she's had prior surgery and enucleation. I think probably would need surgical resection at least for repeat tissue for pathology, and then any adjuvant treatment pending the final path.
Yep, exactly. Uh, Great. So that was the course. The patient underwent a re-resection, again about 5 years after the initial re-resection, and we have the pathology slides here. Dr. Goltikan, if you're available.
Hi, good morning. At the top panel, you see three hematoxylin eosin stained sections. Low power at the top left shows some staghorn type blood vessels. That's what it's emphasized that we used to call some of these tumors hemangiopericytoma, and that elongated branching vascular pattern was emphasized in the diagnosis. Now things changed a little bit. And the middle upper picture, you see a lot of collagen and a spindle cell proliferation. It's typically famously called patternless pattern, meaning it doesn't have whorls, it doesn't have any streaming fascicles. It just seems to be a haphazard distribution of spindle cells in a highly collagenous background. And of course, as you see on the top right, there are highly cellular areas as well as low cellular areas. For the pathologist, it's a matter of thinking about the differential diagnosis. As you guys said, meningioma is, the typical diagnosis in these cases, but SFT, solitary fibrous tumor, which is what this is, mimics meningioma and some other mesenchymal tumors. And at the lower half of the picture, I show you typical immunohistochemistry for this tumor. On the left, there is CD34, which is very sensitive marker for this tumor, but the specific diagnosis comes from NAP2 STAT6 fusion detection, which is done by immunohistochemistry for STAT6, which is nuclear positive in the nucleus in 100% of the cells here. So that clinches the diagnosis of solitary fibrous tumor. And then there is grading, grade 1, grade 2, grade 3, according to Marseille classification. This one seemed to be a grade 1, I believe, because of the lack of mitosis and necrosis and a low Ki-67 index. Thank you.
So it was a solitary fibrous tumor. So just going over some basic features of this. Get out of that. As Dr. Gultekin mentioned, it's a haphazard arrangement with prominent staghorn vasculature and a STAT6 rearrangement. These are all key buzzwords when looking at this particular pathology. You may also recall the name hemangiopericytoma as well, similarly for this diagnosis. In terms of occurrence, equal gender and mostly in adults. And the symptoms primarily depend on the anatomical site, obviously can occur in the brain, in the head, but also outside. And it's typically characterized by a slow growth pattern. As we saw on CT, it's well defined. That is tends to be isodense. And we didn't have MRI, but the MRI features would be T1 intermediate and T2, some variation depending on what's composing of the lesion. So treatment, surgical resection, as long said, is the ideal approach, and also as the gold standard of care with long-term surveillance, which is kind of what this patient had. She also surveillance to her left proptosis, I suppose, as well. There's also a question of combination with radiation, but the role of chemotherapy is limited in these types of tumors. Histologic features, again, to bring home anything, it's a staghorn-like appearance for all of those that were wondering what a staghorn really is. There's an example of it in the bottom right. It is selling for $40 on Amazon, this specific one, but you can kind of see how the staghorn shape reflects what you see also in the vasculature and histology slide. And as Dr. Gultekin said, there are various markers for this, but STAT6 is truly the characteristic marker for that, and that's secondary to the gene fusion that drives the molecular biology. Ultimately, prognosis is good. There is a recurrence rate, as we saw in our patient here, with specific survivals above 70% at 10 years. Excellent. So we will move on. Thank you, Alon. We'll go on to this case 2 now. Vejo, are you there?
Hi, Victor. Yeah, I'm here.
let's go ahead. 34-year-old male. He has some non-specific symptoms of 2 months, headache, neck pain, nausea, vomiting. He has also had some more recent history of dysarthria, confusion, with nothing else really remarkable at that point. The astute ER calls a CT scans. Go ahead. Why don't you tell me what these sequences are and if you can see anything?
Sure. So we have left to right soft tissue window CT of axial, coronal, and sagittal windows. On the left, sort of temporo-occipital, you have a lot of hypo density, likely some vasogenic edema. You may have a brain tumor if he's having dysarthria and these other symptoms, but you can't really say for sure on a CT, so would need an MRI with and without.
Right, there you go. Why don't you go ahead and tell me the same thing, what you see, what sequences?
Sure. So again, going left to right, we have a T2 axial, a T1 axial with contrast, and then T1 sagittal and coronal both with contrast. On the axial T2, there's quite a bit of vasogenic edema on all these T1 contrasted images. There's like a deep temporal lesion, left temporal lesion. It's peripherally rim enhancing. It's heterogeneously enhancing inside. Looks like there might be some necrosis in the middle as well.
So if you had to come up with a differential.
Sure. I mean, based on the peripheral enhancement and this necrosis in there, he could have a GBM. It also looks like, it's hitting midline on the coronal. Other things, I mean, he could have, like, this could potentially be a MET. He has a single lesion, so that's always a possibility. I mean, I don't know if this is kind of cheating a little bit, but you could also just say that he has some kind of high-grade astrocytoma as well, or yeah, I think that those would be my main things for these kind of intraaxial lesions like this.
That's excellent, perfect. And so glioma, primary astrocytoma, kind of covers all those bases that you mentioned. These cases, you can never forget CNS lymphoma as well. And on top of that, inflammatory, infectious causes obviously are there, but not particularly high on the differentials. So again, if you had to come up with a treatment plan for diagnosis and treatment, what do you think we could do?
So I think the easiest way to diagnose and treat would be to resect it. It's a solitary lesion. It's pretty well circumscribed. Maybe left temporal crani, resect that and send it for path to get a diagnosis as well.
Excellent. All right. And that's a surgical resection. You can see the postoperative slide there. And Dr. Gultekin will go to the pathology, the histology.
Yes, so it turns out that this looks like a very highly aggressive lesion histologically, and it's a glial tumor. On the left top, you can see the left half of the slide is all necrotic. The right half is blown up on the right top picture, which shows a glial tumor with giant cell features, huge nuclei over here on the right top. And the Ki-67 was very high. I mean, I couldn't believe what I saw. And so it was a kind of a puzzling lesion. It is definitely a glioma. It is definitely grade 4. Now, what exactly this is was subject to some debate because there was ATRX loss, which indicated a molecular astrocytoma, and there was an apparent IDH mutation on one molecular result that we received. So technically, you should call this astrocytoma IDH mutant WHO grade 4. But yeah, that was something that bothered me on this case. I still don't know what the answer is. Is the IDH mutation really accurate or not? I wasn't sure. But anyways, It is a grade 4 astrocytic neoplasm, astrocytoma versus GBM. That's what it is.
Thank you, Dr. Goldhagen.
Did you look into the molecular pathology of this? Did you see any NGS results or anything?
It didn't show anything that would be unremarkable for a GBM. That's what it's inconsistent.
Yeah, so there was a reported IDH mutation. As you know, since 2021, we do not call IDH mutant tumors glioblastoma anymore. Anything that is IDH mutant, especially with ATRX loss and P53 mutation, that's an astrocytoma. It emphasizes the prognostic differences between the two entities. Also, remember that clinical trial eligibility depends on the pathology diagnosis, so we have to be accurate in the wording of these, even though the prognostic differences, can be minor sometimes. But an IDH mutant tumor should do better than a glioblastoma. Okay, go ahead.
Thank you, Dr. Goldhagen. Vijay, don't go anywhere. This case continues. It's
Okay.
not as straightforward. So this patient was diagnosed with a high-grade glioma effectively and underwent chemoradiation as part of their neuro-oncology care, went by the Stoop protocol. We always say that. Do you have any idea? Can you recall any components of the Stoop protocol?
Yeah, STUP protocol is going to be maximal safe resection, then followed by neoadjuvant chemoradiotherapy. They typically get temozolomide, Temodar, and then they get radiotherapy with that.
Okay, excellent. And it's always going to that next level, chemoradiation, but understanding that the radiation total of 60 gray, and then that there's also with the temozolomide, you get that adjuvant post-radiation dosing of 6 cycles. I just think it's always nice to just have a little bit more detail of what that is. So the patient continued on to his adjuvant therapy, and 1 year later, he presented with all these signs. And you can see them here: nausea, vomiting, constipation, some subjective right lower extremity weakness, and was actually found at this point. What do you think is going on, and do you think there's any need for any more imaging at this point?
So I think some of the constitutional symptoms may be secondary to chemotherapy, but if he's truly having right lower extremity weakness and is wheelchair bound, then I think that warrants getting a repeat MRI.
Okay, repeat MRI of what?
Brain with and without.
All right, and so here it is. Why don't you tell me what you see here?
Okay. So again, looks like we have axial, sagittal, and coronal, or axial, coronal, sagittal, T1 with and without, or T1 with contrast images. Looking at it, especially on the axial, you can again see a new rim enhancing lesion with some central necrosis. Again, deep left temporal, now near the midbrain. So it's pretty consistent with likely disease recurrence. There's some surrounding vasogenic edema as well. That may be contributing to his right lower extremity symptoms if they're extended.
What else could contribute to right lower extremities symptoms if it's not in the brain?
It could be in his cord. I mean, the other thing you can see here is looks like some of the sulci may be mildly enhancing here, but I can't really see completely. If he has like leptomeningeal disease, it could spread down to his cord.
Okay, so on that note, you go ahead and you obtain MRI sequences of his spine. And you see them all here. Let me know, can you see anything on these sequences? Do you want to tell me what these sequences are?
Sure. Looks like, again, we have T1 with contrast. Looks like it's full neuraxial imaging. You have C-spine, T-spine, and L-spine. Looks like, especially on the C-spine, there's some enhancement around the cord. So I think that may also indicate that he may have some leptomeningeal disease extending down into the cervical cord.
Exactly. And if you actually go ahead and That's on the thoracic list, but you can still see there's you know the enhancement from the bottom of the cord as it goes down all the way to the conus. Actually, you can see all that enhancement. So if you had to then give it a word, you would say you think there's a leptomeningeal progression of this disease.
Yes.
So that is it. That is leptomeningeal disease. So I just wanted to quickly go over what leptomeningeal disease was in this setting. It's a particular research interest of mine as well. But leptomeningeal disease, leptomeningeal carcinomatosis meningitis, it's a progression of a primary tumor that involves the pier and arachnoid. Those are the leptomeninges, so that would make sense. That's why we call it that. It's not particularly common, and it's a late sequelae of multiple solid tumors, and is not very commonly reported amongst other sort of primary tumors for primary CNS tumors. But ultimately, any sort of primary tumor with involvement of the leptomeninges can be referred to as leptomeningeal disease. And approximately just over 100,000 cases are diagnosed. But truthfully, the true incidence is difficult to determine because to do this, you need ideally both radiographic evidence as well as cytologic evidence with CSF sampling to really be sure of the spread. So the suspicion is that this is an underdiagnosed condition. And there is suggestions up to 20% of high-grade glioma patients will have this. But again, this number maintains to be proven. The prognosis of this is bad, you know, with the mean survival as a matter of months. You can see here that even in the 90s, when they were graphing survival, median survival remains within a matter of months. And this is it's still primarily consistent with outcomes today. And clinical features, I won't go over this too much, primarily depend on the involvement and the structures involved, as you can see here in this big list. I will draw your attention, though, to the bottom, where there is suspicion that with circulating tumor cells, there are localized inflammatory reactions that disrupt CSF flow, and this can generate hydrocephalus, and primarily is one of the reasons why we continue to see these patients in the operating room a lot at for CSF diversion, given this sequelae of disease. We wrote this together once a patient presented with something similar, asking the question, how do these patients perform after CSF diversion? And you can see that there is a 10% revision rate, and the overall survival after diversion still remains in a matter of months. This type of evidence really starts to question, you know, the role of CSF diversion in this setting, this dismal prognosis, and why we do it, and what we tell the patients. And it remains a topic of discussion in many ways. Radiologically, there is a very high specificity using MRI, which is, again, radiology and cytology being the two key components for diagnosis. Treatment, there's no real gold standard, and a lot of the treatment focuses on improving quality of life. Radiation is often considered for multiple situations across the neuraxis, with a possibility of intrathecal chemo. I just wanted to give a plug as to, you know, what I'm doing, hiding away this year in the lab. We are looking at leptomeningeal disease with me and Ashish. And this patient that Veja just described is actually highlighted in the green box. We actually were able to take his CSF during the procedure, and we're actually able to analyze it for all these different markers down this particular pathway called the TLR4 pathway. It's an inflammatory pathway. And this patient, along with the other patients that you can see in the experimental arm, show increased expression of all these markers compared to these various controls. So when you see me in the operating room stealing CSF, you know, it's really for these control purposes. And so it's very exciting to be able to show that, you know, this inflammatory pathway is involved in this progression at this point. And we can hope to continue our work. On the right, you can actually see an animal model that we've slowly developed to implant leptomeningeal disease within patients verified on confocal, that we hope to now test targeting TLR4 in these leptomeningeal disease patients. So stay tuned, more to come for that. Next, we have case number 3. Case of Dr. Levy's. I call it All That Glitters Is Not Gold. We'll see why in a second. Seth, are you on? Is that you, Seth?
Now it's adding this.
Hey, yeah, can you hear me?
Yeah.
Oh, sorry, I just can you I missed what you had said first.
This is the case of Dr.
Uh so I can't hear anything. No, you want me to go somewhere else?
Really my microphone. I'll go ahead and read the story while you get set up. It's a 51-year-old male who had a renal cell carcinoma 14 months ago, had a nephrectomy, and had history of continued left lower quadrant pain. But he now presents with 6-month progressive low back pain and distal paresthesias in his legs. No bowel or bladder issues, and referred to Jackson from an outside hospital with no significant history. On exam, he is full strength, but he does have a reduced sensation distally bilaterally in his lowers with increased reflexes, no bowel or bladder issues. What do you think could be going on?
Yeah, it's I guess I'd be worried about some kind of lesion in his spinal cord. But probably want to get an MRI.
There's some sequences here for you.
All right. So sagittal MRI, post contrast. Looks like there's a lesion, thoracic lesion, contrast enhancing. I guess I'm just trying to see if it's it looks intradural, but it's hard for me to tell if it's like intramedullary, extramedullary. I think it's looks extramedullary.
Right. I mean, you can see how well notable what is it defined, how well it's well circumscribed as well.
Yeah.
Okay. So given his presenting symptoms, what would be on your differential?
For a intradural extramedullary lesion, I think we can think of like schwannoma, meningioma. Let's see. I think those two are the big ones. Maybe. Sorry, maybe like some kind of a MET, but I think unlikely.
Even with his renal cancer history?
Yeah, I guess. Yeah, true. I guess I wasn't sure if the renal cell MET would be. I guess I would have thought that would be intramedullary, but I guess I can go.
You hit all of them in. Astrocytic schwannoma and neurofibroma meningioma are all sort of possible diagnoses here. Was less likely these are solitary fibrous tumors, et cetera. Is there any more imaging you would want for this patient, given his previous history of anything?
Yeah, probably like MRI brain, and see like the whole spine, and then CT chest, abdomen, pelvis.
Of those, the CT abdomen was done, and you can see evidence of the left nephrectomy there. And so, go ahead. Why don't you tell me what do you think we should do for diagnosis and treatment?
I think we could talk to the patient about removal and do a laminectomy resection of this lesion.
Good. So, what is there any particular thing you can think of what you would need for the surgery, or what type of approach
Yeah, I think for the surgery, I think we do posterior approach, position the patient, supine, to get like neuromonitoring. I don't know if would we use like ultrasound in this case.
Ultrasound is very useful in this setting, especially when you're defining how high and how low to go with your exposure. So you really got it on the head. Here are some photos, and as you said, Seth, ultrasound is on the bottom left here with the gross total resection with Dr. Levy. And so Dr. Gultekin will go to the slides now. Thanks, Seth.
So this was a schwannoma, and I'm showing you at the top a low power picture emphasizing the gross features of schwannoma. There's a thin capsule on the right side. There's multicystic. There's cystic degeneration. There's a lot of dilated blood vessels. There are some hemosiderin deposits, but this is distinctly cystic. On the right side, you see the Anthony A and Anthony B type. The Anthony B is on the left, loose. On the right side, there's densely woven Anthony A tissue. That's also typical for schwannoma. On the left lower image, you see a Verroque body, which is palisading nuclei around a nuclear-free zone, which is at the dead center. So, and it's a spindle cell lesion, overall low-grade looking. Everything is screaming schwannoma here. So schwannoma, WHO grade 1.
Thanks, Dr. Gultekin, schwannoma. And so in the hope of trying to be the first ever reported case in man of a renal cell carcinoma as well as spinal schwannoma, I looked, and we are not the first case, but you can see examples of these concurrent tumors here. But going over schwannomas, these are benign lesions, as Dr. Gultekin said, and typically classic with NF2 syndrome with an excellent prognosis after a surgical resection with a rare malignant transformation. I guess the key words here are Anthony A, Anthony B. So that's loose and compact cells, as well as Verroque bodies for the boards. The majority of these cases are solitary, and they typically occur within adults, with a slightly elder predilection for those within the spine. Symptoms depend on the anatomical site, as there. Radiologically, these are well circumscribed masses that, as you can see on MRI ISO, are hyperintense on T2 with various other categories as listed there. Histologically, again, I don't know if we can emphasize it enough, spindle cell tumor biphasic, and again, compact Anthony A, loose Anthony B, nuclear palisading Verroque bodies with lipid lead and histiocytes. I think these are all keywords that we should know heading in towards obviously boards and general understanding. So the prognosis is excellent with gross total resection. Regrowth is possible, but not very common. And as we mentioned earlier, malignant transformation is rare with these cases. So that patient did well and went home, I think, postoperative day 2.
So Victor, before you go to case 4, in this kind of situation, on the clinical side, if there's any suspicion that this could still be a renal cell carcinoma, you should call the pathologist and say, is there any suspicion on morphological grounds, number one, that this could be something else, and whether or not it's possible to do immunohistochemical staining to further differentiate between the two, which is entirely possible. I mean, I'm reporting to you my morphological observations, but to make it more objective, I could simply do an S100, a SOX10, CD56, collagen type 4. All 4 should be positive in a schwannoma, and more or less none of them should be positive in a renal cell carcinoma. And renal cell carcinoma has other specific markers. So we can always objectify the morphological impression if there is a need, if there's a clinical suspicion to go further. And I think, you should not hesitate to do that in those situations for the future.
Yeah, but that's an excellent point, Dr. Kultikin. We'll take that on board. And finally, we'll go to the last case. Case 4 is Aman. Are you there?
Yeah, I'm here.
All right. Okay, let's rock and roll. 49-year-old male with left arm pain at outside hospital. Only really otherwise significant for this AFib diagnosed recently. Otherwise, no other findings on evaluation. The patient underwent an MRI C-spine given the left arm pain. Now, this is a little bit of an interesting one as to how they get to this condition, but can you see anything abnormal on these sequences?
Yeah, for left arm pain. So I'm looking at on the left, we have a T2, the C spine. On the right, it looks like it's jumping out to me. I see
Let me do that.
pretty
Let
well.
me see the axial as well.
Sorry, yeah. Oh, there's 3 of them. Yeah, I was zooming in. Sorry. So the middle image, I see a well circumscribed. Looks like a lesion around. It's posterior to the maybe C3. I can't really tell. The spinous process. I do see on the T2.
2 sequences, correct? So
Pardon?
I want you to look up because this is how the patient ended up being referred to Dr. Komatar.
Sure, not the spine team.
Right, and remembering where Dr. Komatar primarily operates. The C-spine was done. So why don't you have a little bit look further up and see if you can see anything. Look at the axial, see if you can
Yeah.
see the axial.
Yeah, so on the axial imaging, it looks like we have a T2 axial all the way on the right, and it looks like I see on the left cerebellar hemisphere near sort of the CP angle, we see some T2 hyperintensity, and sorry, in the imaging, I can't really see much else on that.
Yeah, that's fine. So yes, exactly. So all of a sudden you're looking at the C-spine, but you catch something in the cerebroposterior fossa. So you would want dedicated imaging, correct?
Yeah, that'd be my next step.
That okay. So you go ahead and get dedicated imaging of the posterior fossa at this point. So why don't you go ahead and tell me what sequences these are, and what can you see?
So on the post on the left, sorry, on my phone screen, not much is jumping out to me.
Well, what
I
sequence?
mean, no. Sorry, on the post on the left, and then we have on the ADC we have
that's flare, flare, and then
oh yeah, sorry, I have a laptop in front of me, making it a little easier. Yeah, so again, we have on flare, I still see the hyperintensity in the left cerebellar hemisphere near the CP angle.
12 anywhere else, or is it just in the cerebellum?
I also see some extending out. I can't tell if this is all one hyperintensity, but I also see some with the brainstem. Otherwise, on the flare, I think those are the 2 that are jumping out to me right now on the screen. And then on
Too much restriction.
sorry, on the restriction, I don't see any. Let me see if I can change the lighting, go down a bit.
It's not that much, if anything.
Okay. Yeah, nothing. I mean, it's nothing that jumps out at me right now. I knowing where the lesion is, I can actually see some, but very minor.
So why don't you go ahead and just summarize everything in a summary sentence?
So, yeah, this is a posterior fossa T2 flare hyperintensity, not non-enhancing, non-restricting lesion without significant edema or mass effect.
Okay, and so now you have this in your clinic office, and they ask you what do you think this could be?
So looking for the posterior fossa lesions, I mean, you always have to have, I think, a Mettner differential. I mean, lymphoma differential. I'd want, to look at, it could be glioma at this point. It could be, I don't have a high suspicion of this based also involving the brainstem, that this would be a schwannoma.
That would be
Hemangioblastoma, I guess, but it doesn't look like it'd be a very vascular lesion either.
Okay, and so just to go back to the glioma differential, do you have a particular preference for high grade, low grade? Do you think?
Based on this imaging, with the amount that I would think with the brainstem involvement, this could likely be a high grade glioma.
All right. So going over it,
Lower.
with those type of sequence appearances, low grade is always a question. But you're right, if it is a midline lesion that has a particular mutation, irrespective of what you see on imaging, that could also be classified as high grade. So again, within the realm of differentials for sure, PNET metastasis, and also never forget those, the other non-tumor sort of differentials as well, inflammatory as well as infection, too. So what do you think can be done in terms of diagnosis and treatment?
So for diagnosis, I would want to do a biopsy, and that would inform me for what my treatment is. Right now, yeah. I mean, right now, I don't think I would jump to any specific treatment. Don't have a high concern for having to do any, there's not a lot of mass effect, so I'm not, very concerned about having to treat in kind of like hydro or anything of that nature. So I'd want a diagnosis via biopsy first.
Okay, all right, and that's exactly what happened. So, Dr. Gultekin, we have 2 pathology slides for this case.
Yes, thank you. So this was a really interesting case. I'm showing you one of the needle biopsies on the left top. It's everything essentially. It's a small biopsy, and we had several of those which all showed the same thing. So they were in the lesion. I have to think about cerebellar roof nuclei being biopsied also because of the neuronal nature of this lesion, but it was lesional. It was not normal structures. So what you see on the right top is distinct vacuolation of the neuropil, first of all, which is odd. And there's also these cells which look like neurons. They have ample cytoplasm, big nucleus, prominent nucleolus, and on the left lower corner, you can see the morphology much better. They are dysplastic. They don't look normal. They are haphazard. They group, they cluster, and some of them have like ballooning inside them, or some kind of cystic change within the cytoplasm. Some of them had binucleation, and one of the stains called HU, which is a neuronal marker, shows these cells to be positive beautifully on the right lower picture. So here we have no glial component, no high-grade features such as necrosis, vascular proliferation, mitotic increase, etc. None of that. Almost a purely neuronal-looking neoplasm with a vacuolated background. And typically in ganglion cell tumors, gangliogliomas, you do see rosenthal fibers and eosinophilic granular bodies. In this case, we did not see them. So I called it the ganglion cell neoplasm WHO corresponding to a WHO grade 1 lesion. I wasn't sure if this really was a oddly placed example of multinodular vacuolating neuronal tumor, which is a newly defined entity in 2021 classification. Next slide, please. And the usual markers of neuronal differentiation like synaptophysin, neurofilament, it did decorate the lesion, but there were some details which did not really exactly fit with the MVNT reported cases either. You know, synaptophysin, neurofilament positivity, etc. And then you can see the Ki67 on the lower left, which is less than 1% essentially. And as other reported cases, and most glioneuronal neoplasms, OLIC2 was also positive. OLIC2 was purportedly a glial marker, started as an oligodendroglial marker, then found to be positive in astrocytomas, and also found to be in certain glioneuronal tumors. So the upshot is it's a low-grade lesion, it's a ganglion cell tumor, and doesn't seem to have an infiltrative, histology, no high-grade features, and some vacuolation in the background. So the problem is the MVNT as an entity is a supratentorial entity. And I hope Victor is going to talk about this a little bit more. But recently there have been publications about posterior fossa MVNT plus like lesions. And so it remains, a proposition, the diagnosis, and we sent, of course, for molecular studies and methylation subtyping. I'm waiting for their results.
Yes, thanks, Dr. Gultik. And yep, we'll touch on MVNT as well. It's as we said, it was a primary ganglion cell tumor. I just wanted to take a couple minutes just to go over just the basic ganglion cell tumors because they're always confusing, I think, when going over them. But these are typically what we hear more about are gangliocytomas and gangliogliomas based on the composition of these lesions, and they're characterized typically with the BRAF in terms of molecular alterations. And these specific ganglion tumors are commonly associated with epilepsy. They're not particularly common when compared to other lesions, but at least with the gangliogliomas, they're more likely in younger people than older adults. Similarly with gangliocytomas. Again, clinical features are related to the location of the tumor. I don't think there's a need to go over that again. And what's interesting is when you look at the classic radiologic features of these ganglion tumors, they're well delineated cystic lesions with variations in enhancement calcification, which is not what we saw in our case. And what's interesting is if you start to think about what this actually could be, if it still remains, outside the realm of NMVT, could this be a high-grade sort of variant with anaplastic features, if you were to consider that? And it typically isn't, this term isn't really used that much, but again, it's trying to think of what could be abnormal and explain the abnormal appearance. With these specific ganglion cell tumors that are well circumscribed, surgical resection is the true recommended treatment, and these particular tumors have a very good prognosis with good surgical outcomes. Now, to go over what Dr. Gultik was talking about, this MVNT, this multinodular and vacuolating neuronal tumor, it's a new diagnosis, and ultimately, I think this still remains a case report level diagnosis when discussing it. The majority of these cases, as Dr. Gultik said, are supratentorial. And here is one example of one of the earlier case series that really described 8 of these cases here. And you get a sense of what this distribution looks like in terms of the epidemiology. Again, it seems to affect all the ages with an equal sort of male to female ratio. Definitely seems these are all supratentorial in nature. And you can see the appearance, at least on FLAIR, you can see the signal almost more compatible with the case that we presented rather than the more classic description of the ganglion cell tumors here. And so to just try to go and delve a little into this for the end of this talk, it's really this T2 signal that really helps define this lesion here. And the histology, it was hard to find anything definitive as to what would conclusively define this lesion. But as Dr. Gultekin had mentioned, there are some glial and neuronal markers that can be looked for in this case. And I did have I did have two examples of posterior fossa location lesions, but again, they remain case report level. So again, whether or not that's specific or aspecific remains to be seen. I guess we'll wait for the advanced sequencing to make a better diagnosis of this one. But this one was an odd one, and I'm sure Dr. Gultekin, maybe we can touch base later on once you get the sequencing back to see really what it was.
Sure thing.
All right, and that will be it for neuropathology today. Thank you.
All right, good morning. So this is a follow-up to a grand rounds I gave about 1.5 years ago, maybe a little bit more, on quality metrics in medicine in general and in neurosurgery in particular. It actually kind of took a long, twisty course to an actual research project. And I'd like to talk today about just kind of reviewing the reason for this project and then some of the data that we uncovered. We're trying to figure out the utility of a very important and very commonly used quality measure for hospitalized Medicare patients. And we'll talk a little bit more about that. So just briefly give you a little origin story about how this project started, talk a little bit about quality metrics, their strengths and weaknesses, talk about, it's a research project, right? So we have to find a model system, and finally look at the data that we uncovered. So quality measures, this comes from Center for Medicare and Medicaid Services, the source of the data that we're actually looking at. These quality measures are said to be standards for measuring the performance of healthcare providers to care for patients and populations. And that's kind of vague. When we talk about quality measures, we're usually referring to very easy to quantify measures. And I got interested in this because of an incident at the VA a couple of years ago. It turned out that we were under the microscope for not seeing referred patients within 14 days in our neurosurgery clinic. And the big problem was a lot of these patients didn't have MRIs of the spine or whatever part of the body we were supposed to be consulting about. And I said, well, the problem is these patients are going to come to our clinic. They're not going to have their appropriate scans. We're just going to tell them we can't help you, for example, without an MRI of the spine. It's going to overpower our clinic, and the patients are really going to be unhappy. And I was told by an administrator who has since moved on to an even higher administrative and leadership role that no, it doesn't matter if the patients have appropriate imaging. This is a quality metric that's being monitored in Washington. So you have to see these patients. And it made me wonder, is this really a quality measure? It's kind of like the opposite of providing good medical care. And it turns out our brilliant nurse practitioner figured out that we could circumvent this problem just by canceling the consults and resetting the clock to when the MRI is obtained. So I went across the hall. I talked to my friend Ken Nissim, one of our wonderful ENT surgeons who is kind of a history and economics nerd. And he lent me this book called The Tyranny of Metrics. Don't let the grandfatherly smile fool you. This writer, he's a professor of business at one of the Catholic universities. And he's a really funny writer and a very acidic writer. And he writes a lot about how easy to quantify metrics, like how many patients are seen within 2 weeks of their referral, has become in many settings, surrogate markers for what we really want to measure, which is quality of services. So, back in the golden age, here's the Raphael School of Athens. All the doctors got together and in a ladylike and gentlemanly way, figured out what was the right thing to do and which doctors were good, which doctors were bad, who should see patients. except for Diogenes here laying on the steps, kind of scowling at everybody. And that system doesn't always work, right? There are bad doctors, there's incompetence, there's terrible hospitals. So, first during the Enlightenment and then during the scientific and industrial revolutions, people started to realize that quantitative science first started to work for things like physics and astronomy, and then it was applied to other natural sciences, and then other fields, including education, industry, government, the military, and medicine. I showed some interesting slides on quality metrics in the military, which I've deleted, added to the end. So quality measures in the last 50 years or so have become important in medicine, and it's happened for a number of reasons. The idea that the doctors, like the School of Athens, would get together, police our own, and decide who's a good doctor, what are good hospitals. The public just lost confidence that this would happen. There's been a loss of trust in organized medicine. Listened to this podcast a couple of years ago. This infamous neurosurgeon who basically maimed and killed people for years because there was no mechanism in place for stopping him. The rise of consumer culture. I'm sorry, I know a lot of you guys are looking at this on a very small screen like a phone, but this is a Consumer Reports issue from the 1950s where consumers are going to make decisions about cigarettes. They're going to review laboratory tests of 37 brands for tar and nicotine and review the medical report. How good is the case against smoking? So patient autonomy and choice is a big part of why easy to digest quality measures are needed. And then accountability. Healthcare is at least 5%. I think now it's more, 6 or 7% of our gross domestic product. And both consumers, government, taxpayers want accountability by healthcare providers, doctors, and hospitals. None of this would be possible without computers and big data. And now, in the year and a half or so since I gave the first version of this talk, AI, right? Tools. And finally, this is actually not a bad thing, but a good thing. The fact that some simple to measure quality metrics have been used successfully to make medicine better. And we'll give one example of that later on. So the good thing about quality metrics, which are simple, easy to measure variables that are believed to be surrogates for quality care, is that they're simple. Examples are 30-day mortality after a particular, let's say, surgical procedure, the pain visual analog scale, right? There's a lot of ways to measure pain, but this is a simple number that's easy to record. My favorite, which is the provision of smoking cessation materials, this very important metric that helps govern how much we're paid. And it's whether or not we gave a photocopy, of a printout to a patient in clinic saying smoking is bad for you. And here's a 1-800 number to call if you want more printed information. Because they're simple, it facilitates collection, archiving, and analysis of large amounts of data, both for clinical research and quality improvement. It makes the lives easier of people that do, for example, clinical studies. Transparency, because these measures are simple, even non-specialists, even the lay public or politicians can understand and compare outcomes with different interventions or different providers. And it facilitates accountability because these outcome measures are very simple. They can be compared among institutions or providers. So what's bad about simple quality metrics? They are very sensitive to what my favorite quality writer called metric fixation, which is using these simple quality metrics to avoid the burden of complex analysis and decision-making. And that's one form of metric fixation. Another is just making raw numbers public without accompanying education about their limitations. And this kind is a more subtle statistical argument, which is using simple quality metrics to rank, reward, and punish a very broad range of providers. Most quality metrics, if you look at different doctors or different hospitals, they're going to fall on sort of a bell curve with various degrees of steepness or shallowness. And at the very far ends, for the good and for the bad, these metrics can actually identify problems, like that neurosurgeon who killed so many of his patients. But in the broad range of competent providers and decent hospitals, it's actually very hard to make distinctions based on these very, very simple quality metrics. I won't belabor this, but a couple of research psychologists back in the middle years of the 20th century made like little pithy laws about how bad it is to focus on the number rather than what the number means. So the metric fixation leads to a lot of unintended consequences. And I ask you, you can think in your minds how many of these you recognize from our everyday practice and research. Data distortion is one category, and gaming the system is the other. So data distortion is measuring only what is easily measurable. So that's why clinical trials, and chart review studies for cancer patients measure overall survival rather than quality of life. Quality of life, especially Dr. Harris's much hated quality adjusted life year, are very hard to measure. Overall survival, right? People are either living or dead. It's very easy to quantify. Measuring inputs rather than outcomes. So US News and World Report ranks hospitals in part on how many nurses are assigned to a floor with a certain number of patients, how many ICU doctors are on call for an intensive care unit. That's very easy to measure, right? How good of a job those doctors or nurses are doing is very hard to measure. Standardization of data. Lumping rather than splitting data makes life easier. So 30-day all-cause mortality after coronary bypass surgery, includes both the 85-year-old with an acute MI, and the 50-year-old executive with stable angina, who plays racquetball every day. So standardizing and lumping data is a problem. And then gaming the system. This is my favorite. What's called skimming the cream, when our local hospitals send all of their disasters to Jackson to make their numbers look better. Lowering standards, the airlines have done this for years, but now, saying we expect an OR turnover time of 55 minutes. So when it takes 50 minutes to turn over an OR, it's a great success. In a more sinister way, deliberately distorting data. I remember a few years ago, there was a big push. If we were going to readmit patients to the hospital after discharge for a complication, to admit them to OBS rather than inpatient status, because that makes the numbers look better, even though it means the same thing. One horrible case, which I don't want to even remember, was this was a transplant patient who was basically kept alive for exactly 31 days postoperatively. And although I can't be sure, I think it was because 30-day mortality is a big quality metric. And finally, just frank cheating, avoiding certain wording of operative notes. We opened the lumbar spine and we noticed cerebrospinal fluid in the field, right? And also deliberately not collecting outcomes data, let's say not getting certain types of imaging because we don't want to know if there's been a complication. So that sounds really negative and nihilistic, but simple quality measures have led to tremendous improvements in medical care. And an example is central line infections. In the 90s and before, these were terrible problems in American hospitals. It was estimated that 32,000 patients a year died of central line infections. So a critical care doctor at Johns Hopkins, Dr. Pranavast, made a quality improvement project at his own hospital, making a simple standardized protocol for inserting and maintaining central lines. This is what we see now, right? Everyone puts on a gown and gloves. Everybody, gets out of the room. They prep the skin with ChloraPrep. They use an antibiotic impregnated dressing. When I was a medical student, this was not done. This was tested in a prospective multi-center trial, and it led to a dramatic decrease in central line infection rates and mortality. It was a tremendous success. And now it's universally applied, throughout the country, probably throughout the world. And that was using a simple quality metric, right? Which is, central line infections in inpatients. So what happened? So in published studies, this was a success. Central line infection rates approached 0. So the National Quality Forum, we'll talk a little bit about them later. They make a list periodically of never events that should absolutely never happen. There's never an excuse. For example, amputating the wrong leg, or a patient in the hospital who's kidnapped, raped, or murdered. I think we can all agree that those things should never happen. Well, they now consider central line infections to be never events because of the success of this protocol. So Medicare, Center for Medicare Services, collects central line infection quality metrics data. Beginning in 2009, Medicare said they're no longer going to pay for any expenses associated with central line infections. And that metric is part of the 9% of Medicare reimbursement tied to quality. And remember, this is such a rare event now. How do you really rank hospitals in quintiles, for central line infections when the baseline rate is so low? It's had some other unintended consequences. There's a multi-million-dollar industry selling midline catheters, which go to the midline of the body, but not further. So they are considered peripheral IVs for the purposes of calculating central line infection rates, and therefore the manufacturers charge a premium for them. And an email that we received from one of our hospital administrations a couple of years ago saying that our CLABSI rates were kind of high. And it said, to be fair, the email said, please make sure that you're following protocols and, washing your hands, but also don't pan culture patients if it's not indicated. Like, we kind of don't want to know if the blood is infected. So quality metrics have good and bad. We want to ask, are they useful in medicine? So if we want to research that, right, we need a model system, and we need to define what does useful mean. So early on, I actually attended meetings and conducted some interviews and studied a bunch of different quality measure systems or quality metric systems that are in use at our hospitals. Some of them, the Comprehensive Stroke Center accreditation process, is really impressive to me. Medicare Center for Medicare and Medicaid Services quality metrics, I got a little bit concerned about, and I decided to use it as a model for two reasons. One is that they generate patient safety indicator data, which are data on complications. They're very wordy. They have pages and pages of definitions, but they are straightforward to define. They're used universally among hospitals in the US, and they have very broad financial significance, both in terms of direct payment to hospitals and things like US News and World Report rankings. And I also, just looking at them, realize that they may have some potential weaknesses. So they'd be interesting and important to study. So that's what we looked at, Medicare patient safety indicator data. And then how do we define utility? Well, in order to be useful, the quality metric has to be accurate, meaning that it has to reflect the actual occurrence of the event being studied. And it has to be significant. In other words, it has to correlate with what we doctors or experts would consider to be meaningful clinical outcomes. The metric that Press Ganey asks our patients, did they have good valet service at Sylvester? Like, of course, it's important maybe to the patient, but do we consider that to be a meaningful aspect of cancer care? An argument might be that it's really not. And finally, susceptibility to gaming, which is something we can talk about a little bit, but it's very hard to quantify. So let's talk about Center for Medicare Services patient safety indicator data. The CMS is part of the Department of Health and Human Services. Back when I gave this talk, I think in 2021, it was responsible for 5% of US GDP, mostly Medicare payments to doctors and hospitals. Now it's actually more, I think it's 6%. And beginning in 2008, the Center for Medicare Services decided that for a number of political and scientific reasons, there should be an emphasis on value-based payment rather than just paying more and more for the provision of more and more services. I don't want to belabor this part, but there was an Institute of Medicine report that was seen among policymakers as a call by experts for more quality in healthcare and less quantity. There was a roughly 10-year phase-in period during which Medicare began phasing in, basing its payments to a very significant degree on what was perceived as quality of care rather than quantity of care. And where we stand now in MIPS, which is the merit-based incentive payment system, is that it's about 9%, I think, of Medicare payments. I think it went up to 9% and then stayed there about a year ago. There's a whole bunch of different things that go into MIPS, using the electronic health record, cost, what hospitals bill for particular procedures or diagnoses, kind of like random educational activities, bonus points for seeing complex patients. That's a good thing. But 40% of these Medicare quality-based payments is based on quality of care. And one very important metric that's used by Medicare to assess quality is complications, and they call them PSI, or patient safety indicator events. There's other measures too, like whether or not we give a first generation cephalosporin before surgery, but PSI is very important. I think 4%, possibly now 5% of Medicare payments are based on PSI events. And the process for selecting what is a good PSI, what is a good complication metric, is that every year various stakeholders, not you and me, but federal agencies, submit possible complications to monitor to the Department of Health and Human Services. A committee at HHS makes them what are called measures under consideration. HHS publishes a list online and invites public comments, including, like, for example, medical specialty organizations. And then every year there's a committee, again, as far as I know, very few clinicians. It's mostly public health experts and epidemiologists chooses which measures will be measured for the coming year. So what are these patient safety indicator events? These are inpatient adverse events. They have to happen during the hospitalization. They are only tracked for Medicare patients, not other patients, who have either undergone surgeries, procedures. As Dr. Harrows pointed out in an email a couple of weeks ago, a ventriculostomy is counted as a procedure, or childbirth. And the HHS defines these as patient safety indicator events as being amenable to prevention through system level related structures and processes of care. We'll talk more about that later, but here's a list of patient safety indicators. Pressure ulcers, death and low mortality DRGs, retained surgical items, central venous line infections, postoperative hemorrhages. Each of these has here obstetric trauma rates. These are an interesting mixed bag because some of them are so rare that they're actually not routinely tracked, for example, at our hospital, for example, retained surgical items or unretrieved device. Some of them are pretty common. Death rate among surgical inpatients who have another treatable complication like sepsis, shock, or respiratory failure. That's actually not uncommon. That's like 1% of surgical patients. Obstetric trauma rate, for example, a perineal tear, it's also pretty common, a little more than 1% of women who have babies. Some of these are exceptionally rare. Some of them are uncommon, but not rare. Some are very, very serious. Some of them, not so much. A transfusion reaction can mean fever, or a rash. So these patient safety indicator events require 3 criteria. And all of these are based not on chart review, but on the billing codes that hospitals submit to Medicare for the purposes of billing at the time that the patients are discharged from the hospital. Or now our hospital, Jackson, can do it even a year or 2 later for a variety of reasons. So there has to be an ICD-10 diagnostic code for the complication, and it has to be coded by the clerks who put in the data as not present on admission. So if you have sepsis on admission, even if you have a surgery and are septic afterward, you don't get the complication for sepsis. There has to be a CPT or procedure code for a surgery or procedure. And there has to be the absence of ICD-10 diagnostic codes for exclusion criteria. So for example, postoperative hemorrhages are excluded if the patient has diagnostic codes for thrombocytopenia or coagulopathy. Center for Medicare Services detects these PSI events based on combinations of diagnostic and billing codes that are submitted to Medicare for billing purposes. Individual events are reported back to hospitals at intervals. Usually it's every couple of years in a list, presumably for quality improvement purposes. And these events determine at least 4% now of Medicare hospital reimbursement. So a lot of money is at stake. There is also what's called the composite PSI 90, which is a sort of a mixed bag of different PSIs, different complications. It considers the total number of events at a hospital adjusted for the number of, obviously, the number of patients treated, and there is some weighting of the complexity and illness of the Medicare patients at the hospital. And what's interesting is that there's weights both for what are called harm and volume. Harm is how much the complication is expected to harm a patient. And it's really weird. If you look like a pressure ulcer, which of course is a bad thing, but let's say a decubitus ulcer on the heel has a harm weight of 0.3. A postoperative hemorrhage, like especially in our patients, has a harm weight of 0.05. I'm not sure how these are calculated. Supposedly they're based on expert committees. And then volume is how common these are expected to be in a reference population. So these composite measures are actually used in certain things like the STAR rating system for hospitals, which is published online by Center for Medicare Services. And it's also used in a lot of commercial rankings like US News and World Report. In case you're curious about the STAR system, here's a screen grab of some of our hospitals within I think a 10-mile radius of Jackson. Interestingly, University of Miami Hospital is not on the list. I'm curious to know why. Mount Sinai gets 3 stars overall. Jackson gets 1 star. Hey, the VA gets 4 stars. So the question that comes up is, okay, look, so these PSI data are collected by Medicare based on billing codes, which are entered not by doctors, not by research nurses, but by clerks who have taken a billing course and work in the hospital, maybe with some assistance from some computer software. So are they really accurate? Like if the billing code says that a postoperative hemorrhage occurred, did it really occur? Are there missed events? In other words, is it possible that there's events that are not being captured by CMS? And then also, do they have clinical significance? Does do these, let's say, postoperative hemorrhages, are they just some bleeding under the skin, or are they something that actually harms patients? So I'm not the first person to ask this question. On the right, I show a table from our recent manuscript, but a lot of people ask this in the years after MIPS, these Medicare incentive quality payments were introduced, saying, hey, is this really going to be accurate based on billing codes? And what a number of research groups did was they took their hospital's billing codes and they would take a sample, let's say there were 10,000 patients, they would take 100 of them, and they would do their own computerized analysis of the billing codes and say, did we detect these complications, and then do some chart reviews. And they found that for the various complications, there were actually varying degrees of accuracy, ranging, looking at this, anywhere from 40 to 100%, actually 30 to 100%. So these were published back in the early 2010s, but nobody has actually looked at false positive rates. Nobody has published any data on actual CMS-provided patient safety indicator events. I mean, they're the government, right? Maybe they have a much better system than these authors did. And there's actually no published data on the clinical significance of patient safety indicator complication events. So that's what we wanted to look at. So we wanted to ask, is the mechanism for detecting PSI events that the government uses accurate? And that's review of billing codes that are taken from, actually not the chart, but the computerized files that are sent for billing purposes to Medicare. Are there false positives or false negatives? Do these billing code criteria actually correlate with actual clinical events that we can detect by reading the chart? And does the process by which CMS analyzes the billing codes, like, is the government actually capturing the prescribed combinations of inclusion and exclusion codes accurately, as based on our own review of those packages of codes that are sent to Medicare? Second question is, are these events associated with meaningful changes in clinical outcomes? Hey, if we're going to follow this metric and use it for payment, for ranking, it should really be clinically meaningful and not just a random number. So we decided to look at some measures such as length of stay, impairment of organ function at the time of hospital discharge, and the need for additional treatments because of the PSI event. And then when possible, and again, standard of care is such a hard to define term, are these patient safety indicator events associated with breaches in standard of care? We were only able to do that for one type of patient safety indicator event, and we'll look at that when we look at our data. So here's our study design. We did a retrospective chart review study of Center for Medicare Service patient safety indicator events that were reported back to Jackson by Medicare over the time period from July 1st, 2018 to June 7th, 2021. We selected that time period because that's the time period during which CMS provided Jackson with this data. So these are not us looking for complications in the billing codes or the chart review. This is what the government, I hate to use that term, this is what Center for Medicare Services says happened at Jackson in Medicare patients during that time period. Two doctors, myself and Dr. Basil. Greg, thank you so much for your work on this very, very tedious project. What we actually did was we went back and reviewed both the charts and the lists of billing codes for each of the patients, right, for whom these events were reported by CMS. And we independently reviewed them, and we tried to figure out, were they accurate? Were they significant? Greg and I would then meet to see what we agreed on and what we disagreed on. If we couldn't reach an agreement, Dr. Atala, our CMO, who's also very interested in this work, was the deciding vote on who was right. I think Greg was right more often than I was in the few cases in which we disagreed. So this is the data that we collected. Accuracy, whether the electronic medical record review fit the CMS's own criteria for a PSI event occurring, whether the billing codes fit government criteria for the PSI event, and this is important, whether additional PSI events occurred during the hospitalization based on chart review and billing codes, which were actually not reported back to us, meaning not detected by Center for Medicare Services. And then we looked at data related to significance. Were any additional procedures or medical treatments needed because of the event, the complication? Was length of stay increased? Did the event lead to impairment of any organ system or function at discharge? And then only for DVT and pulmonary embolus PSI events, because there really is a standard of care, whether patients receive standard of care DVT prophylaxis. So here's our results. So these are all Medicare patients treated at Jackson Memorial Hospital as inpatients during the study period. So we detected 143, or Medicare detected 143 of these events in 127 patients. Many patients had 2 events, some patients even had 3. Most common were pulmonary embolism or DVT. Perioperative or postoperative hemorrhages were also relatively common. Sepsis, respiratory failure, which just very briefly is defined as either reintubation after the patient was extubated following surgery, or unplanned prolonged intubation for more than 96 hours after an operation. And there's a bunch of exclusion criteria, lung diseases, surgery on the head and neck, and other things that are exclusion criteria for postoperative respiratory failure, meaning that some of these patients may require prolonged intubation, and it's not considered a complication. Kidney injury only requiring dialysis, pressure ulcers, and a very important one, death rate among surgical inpatients with serious treatable complications. This does not mean any Medicare patient who dies after surgery. The Medicare patient has to die, but also have had one of these other complications. Not all, it has to be, I believe, sepsis, kidney injury, pulmonary embolism, and I think shock. Primary service, the transplant surgery service and neurosurgery service were number 1 and number 2. Orthopedic surgery, many of which these were big spine cases. Cardiothoracic surgery, I think were the big 4. Surgical oncology, number 5. And then, combined team surgeries and a whole grab bag of other services rounded out the rest. Solid organ transplants were by far the most common source of these PSI complications. Spine surgery, and we'll look at that in more granularity later, was number 2. Craniotomies, number 3. And again, we'll look at those in more detail. Everything else, was almost represented in, very, very small numbers per procedure. So here's I think the most important slide, which is the validity, the accuracy of the PSI complication events assessed by Center for Medicare Services. So we did 2 types of validity assessments. One was looking at the discharge codes, the diagnostic and billing codes, and saying, even by CMS's own standards, did the codes that were submitted match the criteria for a complication? And then we also looked at chart review. Again, based on the declared criteria, inclusion, exclusion criteria, does chart review confirm that the event actually occurred? Well, not always. So for the criteria for pulmonary embolism or DVT, when we looked even at the billing codes, which should be very simple, right? Only 80% of the CMS reported events fit their own criteria for billing code inclusion and exclusion criteria. When we looked at chart review, interestingly, it was a little higher, 85%, but that's still, 15% false positives. Perioperative hemorrhage or hematoma, based on just by the discharge codes alone, only 78% really happened. If you do chart review, only 34% really happened. And the biggest source of error here was there were a lot of transplant patients who had very low platelet counts, who were coagulopathic. And the fact that they were coagulopathic or thrombocytopenic never made it into the discharge coding. So by CMS's own criteria, only about a third of these PSI events were real based on chart review. Sepsis, pretty good by billing criteria, only 3/4 accurate, 24% false positives by chart review, and so on down the line. Respiratory failure, 53%. Kidney injury actually was pretty accurate. Accidental puncture of organs during abdominal surgery, very small numbers, so it's hard to say. Pressure ulcers, pretty accurate. Pneumothorax, we only had 1 case, and that was inaccurate. Interestingly, it was a transthoracic approach or a transdiaphragmatic approach that included entering the pleural cavity for a spine case. And there was a tiny pneumothorax on a postoperative chest x-ray. And then death rate actually was pretty accurate. Either patients are alive or dead by chart review. Interestingly, a couple of patients should have failed based on discharge coding, because the second complication, in addition to death, that is necessary to fit criteria, never made it into the discharge coding, even though it did happen based on chart review. So, again, very different for different types of complications, but this is a pretty inaccurate quality metric. So, accuracy we're really not impressed with. What about significance? Again, the whole point of this should be a surrogate for quality of care. So I would say it appears to be. Almost every patient who had a chart-confirmed patient safety indicator event actually did require medical treatment, in many cases surgical treatment, or a procedure done because of the complication. For PE or DVT, there was a thrombectomy, a bunch of IVC filters. Pretty much every patient with a postoperative hemorrhage needed to go back to surgery. In some cases, not so much. The most pressure ulcers, just required, local treatment. A few patients required debridement. So I think these were significant. Pretty much every patient required some type of treatment. Increased length of stay was also pretty common, not so much for pressure ulcers, but for our other complications. It did increase length of stay. And in a significant minority of patients, particularly for kidney failure patients, organ function, whether it's the brain or spinal cord or liver function or kidney function, remained impaired at the time of discharge. So these PSI events, when they are accurate, actually do reflect significant clinical outcomes for most patients. Here's kind of an interesting one, which is missed events. So what about false negatives? Please ignore this this line, I think, was a typographical error. But we uncovered, and I'll give you the final tallies at the end, a lot of cases in which patients had a PSI event and the CMS billing code review actually missed a significant number of other complications. So there's a lot of false negatives too. This, by the way, I think is one of the reasons why Jackson administration blocked this research from happening for, there's a number of other reasons, but blocked this research for more than a year. There are a lot of patients who had PSI events based on chart review, even based on billing codes, that were completely missed by Medicare. So false positives are common, false negatives are very common. So what about breaches in standard of care, right? The whole point of these PSI indicators is that not only should they reflect, significant impact on outcomes, but they should reflect substandard care, right, or quality of care by the hospital. So the one complication for which we could really say unambiguously that there is a standard of care is prevention of DVT and pulmonary embolus. So we found 22 patients with chart-confirmed DVT-PE. Of those Medicare patients with chart-confirmed DVT-PE, 18 of them at the time of the DVT were receiving low-dose heparin or low molecular weight heparin with or without sequential compression devices. And in almost every case, this was started on postoperative day number 1, especially in our spine patients. There were 4 patients who, out of 22, who only had sequential compression devices documented by nursing notes and orders. And 3 of them didn't receive pharmacologic prophylaxis because they had clinical bleeding or thrombocytopenia post-op. There was 1 patient who didn't really have clear reasons for not receiving heparin or low molecular weight heparin. So in 21 out of the 22 patients, right, who had DVT-PE, what almost all clinicians and epidemiologists would consider standard of care was met for preventing deep venous thrombosis. So this is our conclusions for all of these, Medicare inpatients, all 127. We can say that most of these reported adverse events occur in very high-risk patient populations. These were not patients having single-level ACDFs or, minimally invasive L4-5 fusions. These were patients having massive, in the spine world, thoracic to pelvic instrumentation, massive multi-stage deformity correction surgeries. In the cranial population, and we'll look at this in a little bit more detail, these were craniofacial cases. These were very high-risk surgeries. A lot of these were solid organ transplant patients who spent months in the hospital. Very few, these were Whipple procedure patients. These were very few patients were at low risk of complications. There were very high false positive rates. Our positive predictive value overall, when the reference is chart review as the gold standard, 76% positive predictive value, so 24% false positives. A little bit better when we look at billing codes, 15% false positives. But isn't that weird? That's exactly what CMS claims to be looking at, a review of billing codes. And it should be very straightforward, but apparently it's not. If we exclude patients who died, where it's much easier to be accurate, right? Because either patients die or don't die. Positive predictive value was only 68%. So almost a third of the PSI based on chart review were false positives. Billing codes remain of similar but imperfect accuracy. False negatives are frequent as well. And I admit that this is just an interesting finding. We really can't quantify it because Jackson CRRC does not want us to look at all Medicare patients' charts during the study period. That was kind of shot down. PSI events are correlated with clinically meaningful adverse outcomes. I give the government credit for this. I mean, the PSI events are very often associated with what we would call a bad outcome for patients. However, for the one PSI event, DVT pulmonary embolus, for which there are widely accepted guidelines for prevention, there was really no association between the occurrence of the event and any breaches in standard of care. So the idea that these PSI measures are measuring, bad care by doctors or hospitals, to me is very questionable. So what do we want to do with these results, right? So I wanted to do some more comprehensive analysis to address a lot of the weaknesses of the study. I wanted to compare the incidence of these PSI, at least in our neurosurgical patients, with morbidity and mortality reports, also for other services like orthopedics and transplant surgery. I'll say this here just with some frustration, you can hear it in my voice. Our information security department at Jackson freaked out about the idea that M&M data, may be maintained by departments in the absence of being regulated by Jackson IT. It turns out our own department discarded our M&M data years ago for legal reasons. So we couldn't do this, at least we can't do it yet. I wanted to review the charts of all the Medicare patients undergoing these neurosurgical procedures during the study period. Would have been a big study. I think there was about 800 Medicare patients. That Jackson wanted to limit the research to what we've done already. So that's been rejected. I wanted to compare the accuracy of the data that Greg and I and Hani Atala found with the internally generated monthly reports from Jackson. So it turns out Jackson has several systems for trying to detect these patient safety indicator events in real time. There's some commercial software that's available. They apparently have a AI generated list, which is really secret. The IT department supposedly created it. We're kind of not allowed to discuss it. We're not allowed to mention it because of concerns that other hospitals may want it. So we weren't allowed to compare accuracy with internally generated monthly reports. They won't give us that data. And then we also wanted to do a multi-center study, which is actually one thing which we're now working on. And then the other thing we wanted to do is publish this in its current form. And kind of bizarrely, I mean, I hate to say it, but I've had a lot of papers rejected by journals over the years. Usually you get back a rejection with saying, hey, listen, this is why we don't like it. There's these weaknesses. It's unacceptable for publication. At Hani's advice, we actually submitted this manuscript to not JAMA and British Medical Journal, but JAMA and British Medical Journal have subjournals that are specifically for healthcare policy. And we thought they'd be really interested. Literally within 48 hours of submitting the manuscripts, they were immediately sent back to us with no comments, no criticisms, just saying that these were not suitable for publication. And I found that a little bit strange because usually when journals take a while, and usually you get back feedback, right? This is why we don't like it, which is very helpful for those of us who have manuscripts rejected, right? We can fix it and then make it a better manuscript. And I'll discuss my theories about that. Actually, Dr. Atala's theories too in a moment. So where we've gone from here is breaking up our big study into smaller ones, specialty-specific data. And specifically, we want to look at neurosurgery data and transplant surgery data. This is more useful, I think, because we get more granular data and specific conclusions for neurosurgery and transplant surgery, which are both specialties that worry a lot about complications. I mean, we are specialties that have high complication rates. This also allows us to split one manuscript into several smaller ones, which has certain academic advantages. And, Hani came up with this idea, and I kind of agree. I think the two journals we sent these to do have a very strong political and policy bias, in favor of big data. I'm sorry to say, but like big government monitoring of quality of care and types of practice. And I wonder if JAMA and British Medical Journal may not be very receptive to this idea that this government initiative, to improve quality, actually may be kind of junky. And we actually may get a more sympathetic reception by surgical subspecialties, including our own. So that's where we're going with this. So we're still working on collaboration with our transplant surgery colleagues, but we were actually able to look at neurosurgery specific data ourselves. And I included the spine data from orthopedics, because in every case that I was able to find, even if the nominal surgical service was orthopedics, our neurosurgeons were involved both in the surgery and the postoperative care of the patients. So this is all spine and cranial surgeries and endovascular cranial surgeries done during this time period. So during this time period, we found 28 CMS reported events in 24 neurosurgical patients. 4 patients had 2 events each. I was able, before CRRC from Jackson shut us down, to get a list, which is we did have 861 surgical procedures in Medicare fee-for-service patients during that study period. So our CMS reported PSI event rate was 3.2%, which actually is well within the expected range that CMS publishes regarding its expected incidence of these complications. So we're not outliers. We found that in this group of 28 events or 24 patients, 11 events, PSI events, occurred based both on billing code criteria and chart review, but were actually not detected by CMS. So that's a lot of false positives in this relatively small group. In terms of the patient population, 61% were in spine patients, 39% in cranial. I write here anterior cervical instrument diffusion. These were not ACDF patients. These were like multi-level corpectomy patients. A couple of them had deformity corrections. These were big spine cases. And similarly for our cranial patients, a couple of them were straightforward brain tumor cases. One was a trauma cranie, but there was a patient with a poor grade subarachnoid hemorrhage who had an exploratory craniotomy because the angio was negative. There was a patient who had a recurrent malignant tumor and abscess. Stroke patients, we know these are, such high risk patients, high reward, but high risk. Craniofacial resection patients, 2 of whom had cavernous sinus exenterations. So these were patients who we would all consider to be at very high risk for complication. This is not a representative cross-section of our neurosurgical patients in general. So very briefly, the positive predictive values. Oh no, I'm sorry. These are the types of PSI detected. DVT-PE were common. Respiratory failure was common. Again, this is not our accuracy assessment. This is what CMS reported. Postoperative hemorrhages, also somewhat common. And death in patients who had an additional complication other than the death. Okay, so now looking at validity or accuracy based on chart review, for the neurosurgical patients, surprisingly, most of these were pretty accurate. Again, small numbers, so it's hard to make good statistical criteria. Death, of course, tends to be pretty accurate because patients are either alive or dead. Respiratory failure, not so accurate. DVT, pulmonary embolus, not so accurate. And the main reason here, again, small numbers of patients, so for a single center study, limited value. But I think the main reason was, for Medicare, a patient who is paraplegic or quadriplegic, that's an exclusion criteria for DVT-PE because these patients are at such high risk of developing deep venous thrombosis. So the reason why these patients were not valid, both by discharge coding and chart review, was that they had the codes for being paraplegic or quadriplegic. They actually came to the hospital. These were 2 transfers from other hospitals with paraplegia, one with quadriplegia. But even though those codes were in the codes submitted to Medicare, Medicare still said that these patients had the complication. Respiratory failure is a little bit tricky to define, both in terms of codes and chart review, but not very accurate based on both chart review and discharge coding criteria. As in our general population, yes, these patients did have increased length of stay and need for treatments related to their complications. Interestingly, I'd have to go back. The two patients with postoperative hemorrhages, I think these were both spine patients, actually did not have any impairment of their neurologic function at the time of discharge. They were rescued by taking them back to surgery. And did these patient safety indicator events in neurosurgical patients correlate with substandard care? I can say kind of subjectively, nearly all of these patients were very, very high risk for the complications that occurred and had multiple non-modifiable risk factors for these complications. Only one PSI event has well-established protocols for prevention, that's DVT. Every single patient of our 4 who actually had valid DVT PE had both mechanical prophylaxis and heparin beginning on post-op day 1. So these were not breaches in standard of care. So the conclusions for our neurosurgery specific analysis, these events occur in our highest risk patients, not our low risk patients. False positive and negative rates are kind of broadly similar to Medicare patients overall. Adverse effects do occur on length of stay and organ system function. And as in the general Medicare population, DVT-PE seem to be occurring in patients who are receiving standard of care. So what are we doing with these results? Greg and I are focusing on the specialty-specific data for now. With the help of Hanny, and we now have a collaborator at UCSF, we're developing multi-center studies that both makes the data and the studies stronger, but also Jackson is willing to agree to expand the scope of our study here if we add other centers so that the published data doesn't just reflect on our hospital. And we do want to compare these accuracy results with alternative methods of quality measurement. I don't have time to discuss it here, but the Comprehensive Stroke Center certification is a mechanism that uses specialists in the field reviewing charts, regular review of the validity of the quality measures that are measured. It actually is a much better but much more labor-intensive way of using simple quality measures. And it would be interesting to compare, for example, neurologic complications between the two types of review. And then for PSI event-specific detection, we actually do want to look both at the text recognition and AI-assisted chart review mechanisms, which Jackson is already using if they let us, and also potentially look at some newer tools and see if those might allow more accurate assessment by the government and by other providers without having to have 2 attending neurosurgeons and a hospital CMO read charts. So that's the end of my talk. I hope that, I hope this was interesting at least, and I'm happy to answer any questions.
Great job, Ron. 2 questions. Who is right in that email argument about the PSI-4? And the other question, that's the one with Roberto on email. And then the other question is, obviously I think Jackson's hesitation about, diving deeper into this, begs a question like, when you find a false negative, what do you do with that data? I mean, if you're doing an analysis and you find that you've overpaid or overcharged for something that's Medicare, related, you have to give back the money. Do you have to do the same thing if they missed a PSI?
So I'll answer both of those questions. 2 excellent questions. So regarding the concern about what happens if a patient dies, if, for example, a patient comes in extremis and we put in a ventriculostomy or even do a craniotomy, right? Do a procedure, let's say, on a dying trauma patient in resus. So the answer is CMS does not penalize the hospital in any way, either financially or reputationally, unless it's a fee-for-service Medicare patient, which is really a very small number of patients that come in through, for example, Ryder Trauma or the Jackson ER. It is true, again, according to my interpretation of the criteria, that for a death to be counted as a PSI-4, there has to be both a death in a fee-for-service Medicare patient, and the patient has to have had one of these other complications, DVT-PE, sepsis, I forget if it's respiratory or renal failure. So if we put in a ventriculostomy in a trauma patient in resus and just the patient progresses to brain death, but doesn't have one of those other complications, in my interpretation of how this data is collected and used, it does not count as a ding against the hospital. In terms of what happens if, for example, we give a talk in a national meeting, which we did, or publish a paper with this data, is Medicare going to come after the hospital? I would say we don't know. It's hard to imagine that would happen, especially because in addition to false negatives, we've discovered all of these false positives. So not that the government is fair, not that life is fair in general, but if Medicare was going to come after Jackson for, unpaid penalties for events that we detected that they did not, they would then also have to refund the money and improve our star ratings, right, for the complications that we found were false that they thought were real. Does the government always work rationally? Does any big administrative entity ever, can we say that they work rationally? We don't. And I sound frustrated just because we've been through so many hoops with Jackson, but I do understand their concerns, both in terms of finance and reputation. And I think that a number of our administrators are right, and probably the best solution is to have multi-center studies. So it's not just Jackson. I agree with them. All right. If there's no other questions, thank you so much, those of you who have stayed with me for a full hour. Have a great day.